Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Ms. Jennifer Verma, Senior Director at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Verma.
Thank you, Val. Hi, everybody, and welcome to our second session in this special on-call series, Shifting Culture, Shifting Care from Usual Care to Chronic Care. Today we're going to continue our discussion on moving from usual to chronic care. I'm Jen Verma. I'm pleased to be your host today, co-hosting this series with CFHI's Improvement Lead, Claudia Amar. Today we're joined by 41 organizations from across the country, and if you haven't already started to do so, we encourage you to introduce yourself using the chat box as I introduce our special guest, Dr. Ed Wagner. Dr. Wagner is the Director Emeritus of the MacColl Center for Healthcare Innovation at the Group Health Research Institute. He and his MacColl colleagues developed the chronic care model, which we'll talk about today. It's an integral part of the patient-centered medical care model. And his colleagues and he are involved in multiple efforts to apply these models to improve ambulatory care nationally and internationally. Ed has written 2 books and over 300 peer-reviewed articles. He's the recipient of the 2007 National Committee on Quality Assurance Health Quality Award, the 2007 Picker Institute Award for Excellence in Patient-Centered Care, and the 2011 William B. Graham Prize for Health Services Research. I'm going to start just by giving us a quick overview of the series objectives, today's objectives, and then some background before handing it over to Dr. Wagner. So this series, it picks up where we've left off in the Caring for the 5%, Healthcare for Those Who Need It Most series for those of you who joined us in the fall and early part of this year. In the 4 webinars that are part of this on-call series, we're really focusing on discussing those challenges along with the requirements to shift our healthcare focus. We're highlighting some of the optimal conditions for chronic care improvement and exploring what kinds of changes are needed to get there. We're addressing the unique challenges of providing chronic care treatment in rural and remote areas of Canada and emerging technologies that can support that type of care delivery, and then importantly understanding the readiness of family caregivers who really provide a great deal of chronic care support in the home setting. Today specifically, we're going to focus on the optimal conditions for chronic care improvement. What are they and how do we get there? We'll explore the kinds of challenges to practice improvement chronic care and talk about what that means from both a patient and provider perspective. So what would the system look like if we were actually delivering on this commitment? And then we'll also learn about the different strategies for motivating the clinical frontline to drive change for improving care for patients and families. So like I said, I'm going to start with a little bit of background from a triple aim perspective. So from a health standpoint, we know more Canadians are living with risk factors for and with chronic conditions, and even more people living with multiple conditions at once. For First Nations, Inuit, and Métis people, the situation is dire. And in many provinces, I think the situation is confounded by the fact that we do have aging populations. From a care perspective, we know from Commonwealth Fund comparative surveys, patient experience surveys locally that people are dissatisfied. I think it's safe to say that the sicker people are, the more fragmented and hospital-reliant and disease-focused our system of support and care becomes. We do rely heavily on acute care for ambulatory sensitive conditions. In many parts of the country, we rely on inpatient alternate level of care beds. I do want to caution that this discussion is really not about acute care versus primary and community care, but rather recognizing we want to rely on both where they're needed, and right now we arguably favor hospital-based care. Finally, from a cost perspective, just rounding out this triple aim, we know we spend upwards of 40% of provincial budgets on healthcare in terms like efficiency gains, value for money. They've become the new healthcare mantra. I think it's important to say that health spending as a percentage of GDP in this country, it has remained steady and has for more than 15 years. But we know we can't keep spending what we've been spending and getting only what we've been getting, as popularly said by Stephen Lewis in Saskatoon. So are we getting value for money? When we consider where we stand on a quality of care perspective, well, data tells us that there's room to do better. We're last and near last on a number of dimensions against Commonwealth countries. And while that's sobering, it also says there is that opportunity to improve. One of the ways that we get to better health, care, and cost, and this has been a mainstay of the series that we hosted on Caring for the 5%, and now this on chronic disease, it really is about relying on that triple aim of better health, care, and cost. And it starts with defining quality from the perspective of someone living with chronic disease. And for them, the triple aim might mean better symptom management, confidence that they can do it, and having access to services they need in home or community. It's also about recognizing that healthcare can't do it alone. It needs to happen in partnership with other sectors outside of healthcare that often more greatly impact health. And it's very much about acting with the individual while having those metrics that allow you to learn for your population. So where this kind of thinking takes us is beyond healthcare to better health, care, and costs, to conversations that prioritize value and what matters from a patient's perspective. And it's also about putting people and communities as the focus rather than letting the systems that exist to drive where we take care. I'm going to turn it to Dr. Wagner, who's going to talk about this in more detail, and will gladly take your questions at the end of today's session. Ed, over to you.
Thanks. Thanks, Jen. I hope everybody can hear me. I want to talk a little bit about the sort of history of chronic care, at least in the U.S., and I will largely be talking from the perspective of primary care, although much that I will talk about will certainly apply to specialty care as well. But our focus on primary care is because that's where the vast majority of chronically ill people are receiving the bulk of their care. And it is that routine care of chronic illness in the community setting, I think, that ultimately determines the kinds of outcomes that are associated with the triple aim. So, a little history. As the world knows, the U.S. always thought it had the best healthcare system in the world until we measured it. This report from our Institute of Medicine, now called the National Academy of Medicine, really opened the eyes of the American healthcare community. This report was published in 2001, so it really was describing healthcare in the U.S. as of the 1980s and 90s. And what it concluded was that all the evidence suggested that U.S. healthcare was mediocre at best, and it was especially mediocre for the chronically ill. And they came to the conclusion that it wasn't a problem of doctors not working hard enough or not being trained well enough. They ended up focusing on the fact that the care systems seemed to be organized for a different kind of healthcare problem than chronic illness. And they said the current care systems cannot do the job. Trying harder will not work. Changing care systems will. And that report has had a major impact. They said that what's responsible for that quality chasm is we had a system that was oriented to acute disease that wasn't working for patients, especially chronically ill patients, or professionals who were trying to take care of chronically ill patients. An acute care system was fine in the 1920s and 30s when acute illness dominated the work of primary care. But as the population has aged, as our ability to keep people with chronic illness functioning and living longer, chronic illness has become a bigger and bigger and bigger part of everyday primary care. We had begun working on this much earlier and trying to figure out how might the system be changed to be a better fit for the needs of people with chronic illness. This is one evidence of our work. It was a Cochrane collaborative review that we did with some Western European colleagues of interventions to improve diabetes care in primary care. And what we found was first of all, there was much more evidence about what might work than we had been given credit for. It just hadn't been pulled together. So for just this one condition, diabetes, we found back in the late 1990s, 40 reasonably well done studies, mostly randomized trials, of a variety of different kinds of interventions to improve the outcomes of diabetic patients in primary care. And what we found was that the interventions, our initial impression was they were all over the map. But as we looked at them more closely, it seemed clear they fell into four categories. There were interventions directed at the provider, at generally the physician, to help them make appropriate evidence-based decisions. Then there were interventions that were directed at that system, changing the system, making it more organized and planful for the predictable needs of people with chronic illness, of increasing the ability to provide follow-up for patients with chronic illness, because it is generally chronic illness fluctuates in severity, and the closer follow-up enables a system to identify complications and exacerbations earlier before they become severe. Information systems was the third area. This was generally in the era before the widespread distribution of electronic health records. So people were using disease registries, for example, to get a better handle on the quality of their diabetes care, to identify gaps in care so that they could reach out to patients who needed service. And then lastly, interventions that were directed at helping patients become more confident, competent managers of their own illness, what we call self-management support. Of interest in two analyses, and I've given you the references, what we found is that as these interventions were bundled into multi-component interventions, they seem to have bigger and more positive effects. And we found, in fact, 5 studies in which the intervention included changes in all 4 of those domains, and those had the single largest improvements in the quality of diabetes care. So that for us was telling. And what we really did, the chronic care model was an attempt to put into a relatively simple graphic form that evidence that I just described. The only thing that's different, so you see in the middle of this diagram the 4 areas: self-management support, delivery system design, these physician-directed interventions, decision support, and then clinical information systems. What we also noted was that 2 other things were important in the care of the chronically ill. One was linkages between primary care and important resources and services in the community that would be helpful to people with chronic illness. Peer support programs, patient education activities, and the like. And then that the quality of the leadership and organization of the healthcare system, of course, was critical to making the changes in the middle of the diagram. The goal is to have more informed, better informed, and activated or empowered patients who have the skills and the knowledge and the confidence to manage their illnesses well and are anxious to do so. And on the other side of what we call productive interactions is a better prepared, proactive practice team. So no longer waiting for patients to get sick and call or come in, but reaching out, monitoring, using information systems to identify people who are overdue for service and making sure that they get service. So that's the essence of the chronic care model. We published it first in 1998, so it is now over 15 years old, and there have been a number of reviews of interventions based on the chronic care model to see whether it in fact has the effect on chronic disease outcomes that we hoped. And the evidence, and I've given you a couple of papers here to look at, the evidence to date has been positive. And because of that, as Jen mentioned, now the chronic care model has been incorporated with some of the old sort of expectations of primary care from Dr. Barbara Starfield and the Alma Ata report, things like continuity and comprehensiveness and access that are not covered by the chronic care model, and all of that now is in most versions of the patient-centered medical home model. So what we've learned over the years now, and we've worked with now literally thousands of practices of all sizes, shapes, and forms, helping them change their systems to be in line with initially the chronic care model and more recently with the patient-centered medical home model. And I think it's important to sort of understand the process of transformation. It is not trivial. Transformation of practice is hard, because what you're asking people to do is to take on new roles, change how they deliver care, change how people in the office relate to one another, while they're still trying to take good care of their patients. It requires investments of time and money on new processes and staff, and for a period of time, it increases stress because it uproots old traditional ways of doing things. Fortunately, once the transformation has become more firmly established, what generally happens is provider burnout decreases, staff satisfaction increases, because they find it not only is leading to better patient care and outcomes, but it's less stressful because it's better organized. What we've learned subsequently is that the chronic care model has these relatively high-level rubrics. Delivery system design. What does that mean? And what we've found is that there are specific functions of practices that are included in those rubrics in the chronic care model that in aggregate, or when applied in a complementary fashion, that is what leads to better outcomes for chronic illness. And the functions that I want to focus on are team care, population management, proactive planned care. So team care and population management is a function both of information systems as well as delivery system design. Planned care is delivery system design. Self-management support is of course, how to help patients become better managers. That of course, links with self-management support in the chronic care model. Medication management has proven in modern chronic illness to be increasingly complex and increasingly important. Care management and follow-up is absolutely critical to outcomes, and I'll show you an example of that a little bit later. So these, and then coordinating care when patients are being cared for by specialists or hospitals or other institutions outside of primary care. What we found is that the best practices, the practices with the best performance metrics, have what in the jargon people would say hardwired these into their care system. By hardwiring, I mean these functions are the standard work of the practice. All the training of staff is around the optimal execution of these functions. The information system, which is mostly now electronic medical records, is tweaked to support these functions. Workflows and standard work are established to make them routine. So that's what we mean by hardwiring. So let me just quickly go through what we mean by, for example, team care. Team care is simply the involvement of the non-physician members of the practice team. In U.S. primary care, that almost invariably means a medical assistant or two, or sometimes even three. It may include a registered nurse. Increasingly, it includes somebody who's trained to be a health coach to help patients improve as self-managers, and so on. There is now strong randomized trial evidence that the involvement of the non-physician members of practice teams in the delivery of clinical care of chronically ill folks may be the single most powerful intervention for improving outcomes in major chronic diseases. Also, what we've learned is that without effective teams, practices find it difficult to do many of the other key functions, such as population management, care coordination. The other thing that we've noticed, and we've been doing a lot of work on practice teams more recently, and I'll at the end of this I'll direct you to a website that we've created to help people develop more effective primary care teams, is that effective practices expand the roles of everybody in the practice so that everyone is working what in the jargon now is at the top of their license, which means they're doing everything that they are legally trained and certified to do. And what that, of course, means is that people are being challenged, and that more and more of the routine aspects of care are being offloaded from overwhelmed providers by their staff. So that's team care. Population management, I hope most of you are familiar with, is that many of the deficiencies related to the reactive nature of care is that gaps in care were frequent because practices were dependent on patients initiating contact with the practice. Population management turns that upside down. Population management is that the practice routinely, for example, monitors lists of all of its patients with diabetes or congestive heart failure, whatever the illness is, looking for gaps in care. Is this a patient, for example, who is out of control with respect to their blood pressure, was supposed to be seen 2 months ago and somehow missed their appointment? We need to contact this patient and get them in. This is an elderly patient with chronic disease and they haven't had a flu shot, and that could be life-saving. That's what we mean by population management. So identifying care gaps and then reaching out to proactively to bring patients in and remedy those gaps. I mentioned another critical function is planned care. One of the issues with reactive care is that waiting for patients to initiate contact, of course, most often patients wait until they have a problem. And so patients with chronic illness would wait, finally develop a problem that may or may not be related to their chronic illness, and then come in to see their primary care practice. Their primary care practice, of course, is seeing them and 20-something other patients that day. They feel obligated to address the problem that drove the patient to the practice, and often what ended up happening is there wasn't much time left to look after all of the elements of the care of their chronic illness, and that was contributing to the care gaps. To remedy that, practices have initiated what we call planned care, and it's simply it begins by looking at guidelines, identify the key evidence-based tasks that are associated with good care, decide who on the practice team at the top of their license is best able and is most appropriate to do the task, review patient data prior to an encounter or a visit to identify the services that they need, and then huddle like a football team, discuss, Mrs. Jones is coming in, she hasn't had her feet, she's a diabetic, she hasn't had her feet examined in 2 years, somebody needs to examine her feet, she hasn't had her eyes examined, somebody needs to refer her to an eye specialist, and so on. And then they structure the encounter so that all of that work gets done. Planned care has been a major reason why there has been a fairly dramatic improvement in office-based care for conditions like diabetes. And I'll end my presentation by showing you some recent data. So that's planned care. How do effective practices implement self-management support? Well, they don't do it all themselves. So the first thing a smart practice does is it identifies resources in the community that can be helpful to patients with chronic disease. And I can't speak knowledgeably about Canadian resources, but I am assuming they're as good or perhaps even better than in American communities. But our communities are full of effective, proven programs for a multitude of chronic conditions that are generally not referred to by providers historically because of either ignorance or lack of systems that enable those kinds of referrals. And that's what we meant by community resources in the chronic care model. But effective practices don't rely totally on community resources to meet the self-management needs of their patients. They organize and train team members to provide basic self-management support. And now there's general agreement on what that is. It involves collaborative meaning between patient and coach, identifying what the lifestyle problems are, developing goals for remedying those lifestyle problems, whether it's inactivity or cigarette smoking, whatever it happens to be, and then developing an action plan to reach those goals, and then routinely following up to see whether or not changes are in fact taking place. Self-management support in the best practices is made a part of every interaction with the patient, either by somebody like a health coach, reinforced often by the provider. And then self-management is a major part of a patient's care and is recorded in the medical record just the same as medications and other clinical elements of the regimen. How to effectively manage medications? Medications, when I was, when I was in training, and I won't tell you how long ago it was, but it was more than 40 years ago, the average type 2 diabetic in primary care was probably taking 2 or 3 medications. And today, the average type 2 diabetic in developed countries is probably receiving in the vicinity of 10 medications plus or minus 3 or 4. So that the complexity of the medication regimen, the dangerousness, if not done appropriately, of the medication regimen means that managing medications has to become a more important part of chronic illness care. So what are effective practices doing differently to manage medications? Well, one, there's a real emphasis on so-called treating to target. For most major chronic conditions like hypertension, diabetes, depression, there are now evidence-based stepped care protocols that one should follow. Stepped care protocols, of course, require stepping up or stepping down and continual monitoring, which historically has been difficult and done only with recurrent visits. So now, evidence-based medication titration can be done by phone, by email, and it's often done now in primary care practices by pharmacists, if the practice is lucky enough to have one, or by registered nurses with additional training using standing orders and protocol. Medication reconciliation, which is that continual review of medications, looking for problems of adherence, looking for side effects, looking for other issues that could be dangerous or having a negative impact on their ability to manage the disease, are constantly reviewed. Multiple people in the practice play a role in medication reconciliation. But I think that of all the interventions and all the functions, maybe the most important is organized, planned follow-up and care management. And we're learning more and more about the importance of managing patients, especially patients with more severe forms of chronic disease, outside the practice. It can't all be done inside during office visits. So what we're talking about here is care outside the practice. And in well-organized teams, that care outside the practice can be as simple as just a periodic phone call from somebody in the practice saying, I understand you've been checking your blood pressures at home. Could you tell us how you feel and how you're doing, and are you having any trouble with your medication? That could be done by a medical assistant. On the other hand, It can be for more complex patients. It obviously needs somebody with clinical judgment, like a registered nurse. So this care, the follow-up care management continuum is absolutely central to improving outcomes. And I want to just show you a little Canadian study that I love to illustrate the power of this, the power of monitoring follow-up. This was a study of hypertension control among First Nation Canadians with diabetes. And all patients were monitored by a home nurse, and they divided randomly the patients into two groups. The so-called control group was still visited by the nurse. The nurse then would just report her findings to the primary care provider. So if there were issues of the patient still being out of control, the nurse would report that to the provider and look to the provider to make whatever changes to medications or whatever else were necessary. In the other group, the nurse had the ability to adjust medications herself by protocol. And here are the results. In the control group, just having the nurse monitoring the patient at home and getting information back to the provider led to nearly a 20% reduction in systolic pressure and about a 7% reduction in diastolic pressure, just by visiting and monitoring. The power of follow-up. When she could adjust the medications, now she gets another 10 millimeters of mercury reduction in systolic pressure and over a 10 millimeter reduction in diastolic pressure. So it's the power of follow-up and the power of involving the team in care. So I want to close by showing you some recent data from our Centers for Disease Control on what's happened to major diabetes complications over the last 20 years. 3 time points, 1990, 2000, 2010. And on the left, for each is, for example, myocardial infarction rates among diabetic patients in those 3 time points, myocardial infarction rates for non-diabetics. Strokes, amputation, lower extremity amputation, and then end-stage renal disease. And I think what you see are dramatic reductions in the incidence of myocardial infarction and stroke, especially among diabetics, much more so than among patients with other conditions. And significant but less dramatic reductions in amputations and end-stage renal disease. I mean, the reductions in myocardial infarction and stroke are breathtaking. So what accounts for this? It can't be all reductions in cigarette smoking, because you should see the same effect in non-diabetics. Here's what the authors of the article said: why an increased emphasis on the integrated management of care for patients with chronic diseases, including enhancements in team-based care, patient education, i.e. self-management support, disease management, clinical decision support. Exactly the things we've been talking about. So I would urge that you take a look at 2 websites. One is summarizes a lot of our work on the chronic care model and on the patient-centered medical home. That's improvingchroniccare.org. And then our new website, which focuses on the primary care team and how they do those functions that we just described. Thank you very much. I look forward to your questions.
Ed, thank you so much for that insightful presentation. I'll encourage our participants, and we have almost 100 lines here active and surely representing even more people and listeners on today's call. So please take the opportunity to use our chat box, and then I'll verbalize those questions to Dr. Wagner. First and foremost, thank you so much, Dr. Wagner. And I have a question that I think some people may be thinking about in terms of initiating some of these changes that you've described. I think some people would say that, you know, part of it is about incentivizing this behavior change on the part of providers and how they work as a team, while others might say we need to create some dissatisfaction and discomfort with mediocrity in quality of care. In your experience, how do you motivate the clinical front line to really work together to make these changes?
Good question. I think the most important motivation is measurement, which was really the second thing you mentioned. Until a practice measures, it is very difficult to convince it that it needs to improve. And then, with respect to financial incentives, what I think our general experience is that financial incentives help the motivated practice continue the work, but financial incentives are not terribly motivational to practices that are really hell-bent to continue doing what they've always been doing.
That's really helpful, Ed. Thanks so much. In terms of the practice composition, I think you said you said a lot of things that were powerful, but you said that the team, sort of delivery of care by a team, and particularly the composition of that team with non-MD involvement, is arguably the single most powerful intervention in delivering on good chronic illness care. The website you provided, improvingprimarycare.org, it gives some profiles of members of the team. I just wonder if you could talk to us a little bit about what you've learned in that work on who are the members of the team and that composition that will lead to success.
Well, I'm happy to do that, but just a little background as to why the team is so critical and why it is in empiric research the most powerful intervention. And it's because the work of modern chronic illness management takes a lot of time. There are a lot of tasks, and it takes a lot of time. There are thought exercises in the literature that suggest that it may take as much as 8 hours every practice day to simply meet all of the chronic illness care needs of a panel of a reasonable size. So that's why it's critical. Teams as small as one doctor and one medical assistant have been shown to be much more effective. So just adding one medical assistant, which in our country is almost a minimum wage job, I'm sad to say, can make an enormous difference, because then you have somebody who can do population management. You can train your medical assistant in basic self-management counseling methods so you can do a little more health coaching. Practices that are lucky enough to be either large enough or wealthy enough to have a registered nurse, of course, can do much more. And so I think the core team for most effective practices is provider, medical assistant, front desk person, receptionist, and they involve receptionists in clinical care. So receptionists can make phone calls to patients saying, we noticed that you haven't been in the last 6 months and that your blood pressure was still not perfect, so we'd like you to come in. So that's what we would see as kind of basic. Then if you're lucky and large, you can get pharmacists and social workers and behavioral health specialists and so on. But just a medical assistant and then a nurse, and you see things improve dramatically if they're used properly.
That's helpful, Ed, because you've also in that answer helped us to understand, it's not just about the team composition, but then extrapolating, well, what are members of that team then doing? With that additional sort of medical assistant, with receptionist, it allows you to get to that point that you talked about in terms of the follow-up component and not sort of thinking about this as a point of care. So, there's lots you can do when the patient is in front of you, but actually thinking about that continuum. Similarly, from a metric standpoint, it's, there's the different degrees of sophistication, but what you're talking about are things like, let's follow up on those conversations that we had to continue that continuity of care beyond wherever the walls are that you're providing those services.
Yeah, that and then, of course, with a medical assistant, you can do with a medical assistant and an appropriate electronic medical record, you can do planned care quite easily. So those two things, planned care and follow-up, I think are the two major determinants of outcomes. The others make a difference, but those, I think, are the core.
That's really helpful, planned care and follow-up. We've got a question now from one of our participants, Sherry Sterling's calling us from Alberta Health Services. She thanks you for your presentation, Dr. Wagner, and she says, can you give a specific example of a clinic or health system that is operating with all of these principles? And then talk about some advice on first steps, which I think you've just started to get at in terms of the planned care and follow-up and team composition. But any specific highlight examples you would point to that are exemplars of delivering what you've talked about today?
If you go to improvingprimarycare.org, much of what's in that website is derived from our study of 30 high-performing practices across the U.S. And then there are little descriptions of those practices, so you can try to find a practice that is closer to the reality that you're dealing with, because some are rural, some are urban, some are big, some are small, and so on. I wish I could give you a Canadian practice, but maybe Jen can.
That's a good point. We've actually, the call that preceded our call today, we certainly talked about, we heard from Jeff Turnbull and the work that he's been doing here in Ottawa, the Intercity Health Program that really targets underhoused homeless population living with mental health addictions issues. And we also heard from a family health team led by family physician Claire Liddy. So I would point to those examples, and we'll certainly reference others in the upcoming calls. I do have a subsequent question here, Ed. So if the team is not co-located and are not all electronically connected, how can they contribute to integrated care plans? Is there an integrated care plan given to the patient in this vision of what you've described today?
Ideally there is. And increasingly, well, let me say this, though. There's a lot we still need to learn about care plans, because historically care plans have been written by doctors theoretically for patients, but mostly for doctors. And patients often did not feel ownership of those care plans. So there's been a movement, I think an important movement towards making more collaborative care plans that patients understand because they are co-producers of it, and B, are more likely to follow because it includes their, or at least acknowledgement, if not actual alteration in accord with their preferences and values. So shared care plans, and nowadays with all of the various forms of electronic communication, there's just a variety of ways with some creativity to keep everybody informed.
I'm going to pose our next question, but I'm going to come back, and I'm just looking quickly here for an example I just learned about that provided. It was addressing the question of, folks not being co-located and some of the workarounds being about how they can do that. I'll come back to that question and provide an example, but I'll move on to Ed. You'll know, of course, Scott Robertson, who's our current Harkness Associate and the previous Chief Nursing Officer in NWT. So he says, it's great to hear you present again. He says the concept of patient education is very broad. Is there evidence of what specific teaching really makes an impact?
Good question, Scott. As I say, the best evidence supports the kind of goal-oriented development of shared goals and then shared action plans and then problem solving around difficulties encountered by the patient in the execution of the care plan. That general approach, which is very patient activation oriented, I think has the best evidence of effects on outcomes. Specific kinds of formal skill training is important, no question. I mean, diabetics need to have a certain base of understanding of their illness and its treatments, and they certainly need to have the skills to self-monitor and administer insulin. But I think the focus is again on empowerment, goal setting, and action planning. I think that's where the evidence is best.
Fantastic, and I'd encourage Scott too to look at some of the references from the previous conversation that we had with Dr. Liddy, who's done some work recently on self-management education and patient education and provided some recent syntheses. And I'll just mention the initiative I wanted to mention to M. Mead in terms of co-location. There's something called the ECHO project, folks may be familiar with. It's an innovation that came out of the U.S. but now has application globally, including a pain project that's located in Ontario. But it essentially connects specialists and primary healthcare providers that in a way that helps them to give a full assessment of individual patient cases in a multidisciplinary approach and really guides them on management and further treatment for each patient case. Just one example of where there wasn't co-location, but there was a commonality of working to improve care with an individual and their family, and that they created that support to be able to do it. Another question that we have that's come in, again from Alberta, but I'll first just mention to folks, check out Karen from BC. She's provided a great example of these types of practices in Canada. So the integrated health networks that she references, the joint initiative between the Ministry of Health Services and the health authorities, and she describes them in great detail in terms of the composition of the teams and how they operate, and the patient as a key partner and team member in his or her own health care. I'll move on now to Nanya from Alberta Health Services question. She's thanking you for your presentation and in organizing and training team members to provide self-management support. She asks, have you done any study into what provider competencies may be needed in providing effective chronic care for patients, or what competencies patients may need in better self-managing their own chronic conditions?
Well, I think the competencies on the provider side have to do with really doing patient-centered counseling that enables the patient to feel that the process is truly collaborative. So most commonly in the U.S., I'm not suggesting it's the best. I'm just suggesting that the training that U.S. practices that really want to do this well are looking for is motivational interviewing training. But motivational interviewing is just one of many patient-centered approaches to collaboratively coming up with an approach to self-management that is acceptable to patients and much more likely to be acted upon. I hope that's helpful and responsive.
And I'll reference too, Ed, that on the topic of motivational interviewing and these questions around types of competencies and what that looks like, especially given you may have some patients who are very gung-ho right up to the spectrum of, well, maybe patients don't share that particular goal of self-management, or for whatever reason it's hugely complex. We did do some webinars with Michael Vallis, who's a behavioral psychologist at Dalhousie University, who provided some really nice guidance around that. It was part of the Caring for the 5% series, so I'd encourage folks to check out that particular webinar as well.
The only thing I would say about patient competency is that patients historically have been so battered by the healthcare system. They've been told so many times that it's their inability to stop smoking or their inability to lose weight that is making them sick. You can't dismiss them as inadequate. It has to do with the way they were previously treated. So don't give up on patients because they have a past history. That's all I will say.
Thanks, Ed. That's really helpful. What I'm going to do now is I'm just going to mention to folks some of our upcoming webinars. And then we're going to run a live poll. You won't see the responses in real time, but I'll pose the questions for you. These are upcoming webinars that you can participate in, single entry models for improved access to care, one that's actually on social networking analysis as a tool that we've been using to understand collaborative healthcare improvement. And those are actually both offered at no charge. They're informational calls. And then subsequently, the next two sessions in this series are going to focus on supporting carers and caregiver readiness, and then finally a full topic on telehealth and its capability in being able to lend improved chronic care in rural and remote regions. Before we end the call today, we do have a few polling questions that we hope you'll stick around to address. So for the following statements, we're asking you to answer 1 for strongly disagree, and 2 for disagree, 3 for neither agree nor disagree, 4 for agree, 5 for strongly agree. And if you think the statement's not applicable, then you can certainly indicate so. But we're curious to know to what extent the webinar has helped to increase your understanding of optimal conditions for chronic care improvement, to what extent it's helped to increase your knowledge of what distinguishes good care from usual care, to what extent it's helped to increase your knowledge of strategies for motivating frontline clinical staff to make these types of necessary changes, and then your overall satisfaction with the webinar. And of course, if you also have any other comments or suggestions, we build our webinars around what you need. And so actually, if you really enjoyed today's webinar, you could thank yourselves, because you're why we invited Dr. Wagner to come and talk with us today. So I'll give you a moment to fill that out. As we do that, Dr. Wagner, if there was any closing comments you wanted to make, I'd love to give the final word to you.
I don't, Jen. I think the secret to good chronic illness care is to build a robust primary care system that can meet most of the needs of these patients in their own communities.
Thank you so much. So I'd like to thank you, Dr. Wagner, for your presentation today, for all of our participants from across the country who participated. We will leave this poll up and live to encourage you to continue to input your responses. And I want to thank you, and this does conclude today's webinar.